faculty. We are doing this course on cataract complications and tightrope situations. So it's walking the tightrope in challenging cataract situations. We have a stellar faculty and a lot of exciting situations which are tightrope situations. So we will be having Dr.Shreyas Ramamurthy speaking on cataract surgery in extreme hyperopia and nanophthalmic eyes, shallow ACs. Dr. Kumar, who will be speaking on handling subluxated cataracts the right way. Dr. Chitra is already here. I'll invite her up to the stage. Is Dr. Kumar here? Would like to call him up. Dr. Harshul will be speaking on Phaco in Intumescent and Morgagnian cataracts. He will be kicking off the program today with his first lecture. Can we have the first slide from my laptop, please? Can we have the first slide from my laptop? And then I will be speaking on how to handle tightrope situations with posterior polar cataracts, including situations where you might have a pre-existing PC rent. There will be challenging pediatric cataract surgery situations discussed by Dr. Sri Ganesh, and Dr. Harshul and Dr. Chitra will be speaking on Phaco in corneal opacities and compromised cornea. So we have it all, and it should be a wonderful program, and we will have scope for 1-minute discussion after each talk. We won't leave them right till the end. So please be prepared with your questions. After each talk, we will take 1 or 2 questions at the most, and then we'll go on to the next. So Dr. Harshul Tak, a prolific surgeon from Jaipur, he has to his credit that he's been invited about 7 or 8 years in a row by Bob Osher for his symposium in the ESCRS on the film festival for challenging cataract phacos, and I think he gets an automatic invitation now with all the range of nice videos that he has. And Harshul, please go ahead. Yeah.
No, it's not working. So good morning, everybody. At the outset, I'd like to thank Dr. Gaurav for making me a part of his course, and I'd like to congratulate the entire local organizing committee for wonderful arrangements at this beautiful venue in Coimbatore. Yes. So I'll be speaking about the phacoemulsification in Intumescent and the Morgagnian cataracts. So we all know that Intumescent cataracts, they always pose a great problem to any cataract surgeon because there is an increased intracapsular pressure in the capsular bag. So this is one-stage capsulorhexis if you want to do in this Intumescent cataract. So at some point you lose it and you have Argentinian flag sign like this. So these are very old videos, 12 or 14 years old videos. So there is another way of debulking the capsular bag. You just give a nick in the anterior capsule and start debulking with the cannula. So sometimes if you are lucky, you may succeed in debulking the capsular bag without extending the capsulorhexis, and you can convert this capsulorhexis. But the problem here is that when you are trying to debulk through these irregular margins, these margins may give way from any side, as you can see. So the technique which I presented in ESCRS 2010 Paris, what I call is a sequential 2-stage capsulorhexis works best in my hands at least. So I always give analogy of the Intumescent cataract to this dome. As you can see, if you want to walk on this dome, the central area of the dome is the safest one. If you want to walk on the mid-peripheral area, there are high chances that you'll slip down. So the same principle applies here. You can see the spokes of the liquefied cortical matter, which is increasing the intracapsular pressure. So I go ahead and give a small nick in the anterior capsule and use a microcapsulorhexis forceps to make a very small opening in the center. And you can use a high molecular weight OVD if you have with you. Otherwise, you can also do with the simple HPMC in cases like this. So once you have this small opening in the center, this is very robust opening. It doesn't give way. So now you go ahead with the 27 gauge cannula, and you can see the whole cortical matter is coming in this cannula. Go from the side port, debulk, and as I'm aspirating, you can see the whole capsular bag is debulking, and the pressure in the capsular bag comes down. So go from the main port, from side port, from second side port, and debulk the capsular bag like this. And after this, I use a micro scissors here, give a tangential cut. And now, because there is no increased intracapsular pressure, you can make a capsulorhexis of adequate size. of 5 or 5.5 millimeter in the one go. So now I'm completing the capsulorhexis. So you should have these microcapsulorhexis forceps and these micro scissors, which comes very handy in situations like this. Most of the cataracts, these intumescent cataracts, they are very brittle, so there's nothing great in chopping them. But still you need to be careful, as there's no cortical support there behind the nucleus. As you can see, I given the first chop, and there is no cortical cushion which is there, so you need to be careful that you don't have any surge, so that your posterior capsule doesn't come in the phaco tip. So step by step you chop them and eat them like a piece of cakes. Always slow down on your parameters when you come to the last piece. This is the Morgagnian cataract. The problem in Morgagnian cataract is different. There is no raised intracapsular pressure as such, because as soon as you give the nick, the whole cortical matter comes out. But the problem lies with the loose zonules and the fibrotic anterior capsule which is there. As you can see, when I'm making the capsulorhexis, this capsular bag is moving along with this. So you need to support with the other instrument if you want. And because of these fibrotic plaques which are there in these kind of cataracts, sometimes the capsulorhexis size may be smaller, so you again need to enlarge the rhexis before you start your phacoemulsification. Now the whole nucleus here is very small and it's very mobile, so it's difficult to get a good grip on the nucleus. As you can see, it's rotating freely in the capsular bag. Now the trick here is to go with the bevel down and get a good purchase of the nucleus, and once you have that, pull it towards you and get the chopper from the equator. There's a classic horizontal chop, as we know, and divide the nucleus in smaller pieces. And again, there is no cortical cushion here, so you need to be careful that you don't have surge in your system, which may compromise the posterior capsule. This is another case, the Morgagnian cataract. The whole, you can see there is only nucleus, there is no cortical matter here. So I go ahead, stain this capsule and make the capsulorhexis. And as I'm making the capsulorhexis, as you can see, I'm using the support of the nucleus. I'm moving the nucleus to get first the support, then secondly to get a good visibility of the stain anterior capsule. So I keep on moving this nucleus and complete the capsulorhexis of adequate size here. And once you have the capsulorhexis, again go ahead, bury the phaco tip and chop it into smaller pieces using the horizontal chopping technique, and the whole nucleus is out, and here goes the capsular, the IOL in the capsular bag, and with this completes the case. So I think in Intumescent cataracts and Morgagnian cataract, it's nowadays with the decent machines which we have and the techniques which we use, it's very easy to get away with these kind of cataracts. Thank you very much.
Harshul, I think what you showed with that small, initiated with this very small rhexis, I think it works very beautifully in my hands too. But what is your most preferred technique? Like, which is the one which you, like amongst the 2-3 ways that you can tackle these intumescent cataracts, which is the one which works for you 90% of the times?
This is the sequential two-stage rhexis which works best.
Yes. Did you try decompression of the lens, like, going in with a,
yes, of course,
30
but
gauge?
as I said, in many cases you get away, but in some cases, because the margins are irregular, so it can get away from any side. So if you have a small, robust opening in the center, which is very strong, you can debulk the capsular bag nicely, and you can have a good size of capsulorhexis at the beginning itself. Because if you have a very small rhexis, it's a problem. If you have a big rhexis, it's a problem.
And the punchorhexis?
I don't think it's predictable.
It's not predictable.
Not at least in my hands.
Yeah. Can you switch on the mic for ma'am, please?
I have just a small question. You did that small rhexis, and what did you, after the rhexis, what did you do? Did you aspirate your cannula? What did you do exactly?
See, after you make a very small rhexis, you again put the OVD, and then you go with your 27 gauge cannula from the main port, go there and suck with the cannula.
With a syringe you...
Yes. It's a 2 ml syringe, and I'm sucking it. And you'll see the whole liquefied cortical matter is coming up, and at the same time the capsule bag is debulking. Go from side port again
Okay,
debulk.
okay.
So once you have debulk, the whole pressure has gone down.
Okay, I've never used it. I never saw it. That's why I was surprised. You are aspirating. Okay, so
Yes.
that debulk.
Yes.
And then you do the nick and bigger
Yes.
nick.
Yes.
That's
you so much.
actually the most important. You're reducing intralenticular pressure. That's
Yes.
what's actually happening. So you're just aspirating the liquid cortex out.
So
Any hydrodissection cannula you can take and just aspirate.
excuse me.
Yes.
Yes,
I
sir.
have a question. If you look at the microcapsular axis in detail, we have the curves of the cystotome and a very area of a capsular axis forceps. If our side port, we make it small enough so that there is hardly any leakage from the side port when we do a capsular axis, the microcapsular axis forceps. We can go inside, like we do with a cystotome, we cut and grafts it. Once there is no leakage, and once we have grafted it, we can proceed like a capsular axis, and it will never leak. And we can complete the capsular axis. Even we can do large capsular axis in this type of cases. And I presented such a case in Assam. Thank you.
Can you switch on the mic of that podium, please?
Okay, great. So thanks, Harshul. I think I'll go on, and very valid point told by you, sir, and I think we all agree with that. So I was going to share a few situations of a posterior polar cataract and tightrope situations. I pulled out one case which I presented to ASCRS in 2003, and it just reminded me of how my technique has evolved handling these posterior polar cataracts. And what essentially we noticed in that patient at that time was that I had started off with hydrodissection, and I was aiming to do only a hydrodelineation, but my rhexis was small. So if you'll notice here in this patient, this is a very old video, almost 15 years back. So then we tried to do a hydrodelineation. As you see, I'm trying to embed. But frankly, these posterior polar cataracts, even when you are doing a hydro, some of the fluid will actually escape and try to go into the hydrodissection plane. So you have to be extremely careful, that you have to be gentle and ensure that you don't go there. And now you can see here that as I'm starting off, you can already see the nucleus kind of moving in a funny way. And my rhexis is small, so if you have a small rhexis, more risk that your hydro procedures will cause some pooling of fluid and risk you to have a break. And you can see now the nucleus is already moved, and it's now going to be a situation, and we'll have to manage. So this nucleus actually sank. You can see it almost standing vertically now, and we have to follow it up by a pars plana vitrectomy. Now this patient was somehow happy with his first outcome. We had done a secondary lens implant for him. He came back to me for the second eye, and this time we did it more carefully, and you can see that it's a bad posterior polar cataract. So at that time I was thinking of newer techniques of how to manage these posterior polar cataracts, and I remember that we had made one port here and make a bigger rhexis, and then we went with a 2-port phaco. So you can see here I am doing the phaco from one port at this time, and then trying to do phaco from the second port, so using the left hand, and I was able to debulk the nucleus completely, leaving this behind. So one of the techniques described was a 2-port phaco. I think Harshul has also done this, and way back in 2003 I had done a few cases like this, but eventually I found it too cumbersome, so of late now I don't end up using this much. But this did work well for me for this patient, and we came out good. And now let me take you to what we currently would do. Another patient where, if you'll notice here, there is a pre-existing posterior polar cataract with a pre-existing break. So if you'll notice here, there is this big PC rent already visible here. Fellow eye, this patient had an ACIOL operated elsewhere. So even when we were starting off, I was wondering whether I should do an ECC or an SICS or a Phaco. Then I decided that in my hands, Phaco works best. So I would have better fluidics and better stable chamber and a more controlled environment. So I decided that we'll go with the Phaco technique. So I just wanted to share with you, this is a typical tightrope situation which you can have with the posterior polar cataract. Now we did a hydrodelineation so that we dissected out an epinuclear shell. So I like to call it as the epinuclear, you can call it as the hood, or whatever Dr. K.K. Mehta uses, the Hema hood, and this is something like a, what you call a scaffold that you're using. So it's an epinuclear shell which you've created, and you've dissected out an endonucleus, and you're not going to rotate this nucleus. So at no point should your the infusion should go off. There should be no fluctuations in the chamber, and at any point if you're going to come out. So you can see here, I have not done any rotation. I have done a good hydrodelineation, and I'm now, we've removed 2 chunks of the nucleus without any rotation, and then I'm easing out the remaining part of the nucleus out of that epinuclear shell or the bag which we've created. So we've created an artificial PC of the epinucleus, and then managed to use that to form a kind of a scaffold on which we are now removing this endonucleus. So once the endonucleus is out, you can see the fluidics have to be slow, so it's a slow and steady kind of phacoemulsification, low bottle height, low parameters, low vacuum, low power, and a very controlled environment. Don't let fluctuations happen in the chamber at all, because it's the fluctuations which actually change the milieu inside the entire chamber. Now you can see here something which probably is thing which you should not be doing actually, because you're trying to use a phaco handpiece, but for me somehow it is something which I sometimes do to disengage the epinucleus from the equator of the bag. I will not remove the complete thing, but here we've kind of debulked the epinuclear shell as well, and now injecting viscoelastic from the side port. So I would not suggest that all of you do that maneuver which I just showed. It is much more controlled to use your bimanual IA systems to do the same thing. It's maybe a little tedious, but it works well. And now I'm disengaging the cortex from all around, so 360 degrees. I'm not going to aspirate it. I'm going to leave that central chunk right for the end, and I'm just disengaging it from all 360 degrees so that we have a fully free floating epinuclear shell, so that once it is all free, then it becomes very easy to aspirate it. This is a very, very important principle in all posterior polar cataracts, that you have to disengage it from all 360 degrees and then attack the central part in the end. So we are just debulking all of the epinucleus there. And now you can see the last part is left behind, which I'm now aspirating. And once that is aspirated, you'll be able to appreciate the big PC break which was pre-existing, which I had shown you. There it is visible, and the anterior vitreous face was still intact, so we were lucky we got away with without any nucleus. So the trick is that even with a pre-existing big PC break, if you are very careful about all the maneuvers that you are doing, you can still get away. And I have done, and most of us would have done, I think, several cases which come up like this with a pre-existing PC break. But the main thing is to be alert and detect that it is there, so that you can plan your surgery properly. Then you can actually put in the lens in the bag, and I will take you to the end of this video where we put in the lens in the bag and did an optic capture, and it worked well. So coming on to another patient where we had a complication actually, and here again it was, we went in very nicely from the beginning of the surgery using the same principles as before. So I'll take you to a midway part of the procedure where we managed to get the nucleus out, but I was a little rash. So this is a bit of a fast forwarded video, but I was rash, and exactly the same thing happened which I warned you not to do. So I wanted to show you this video, that if you are a little rash and if you tend to use now there goes. So essentially this was the very, very important step where you make a mistake, that if you don't let that last part remain attached in the center right till the end, you will possibly get a PC break in spite of doing a great job of the first part of the surgery. Now once the PC break happens, in posterior polar cataracts it is usually an uncontrolled kind of break, which is very difficult to convert into a primary posterior rhexis. So in such situations you will have to go with triamcinolone assisted vitrectomy if you've broken the vitreous face, and it's always very, very important to have Orocort is freely available, and there are other ones as well, and it is invaluable to have triamcinolone with you. Once you've removed the vitreous, you can then nicely remove all the cortex from the bag, and you may still get away by implanting your lens in the bag if you have been careful by not allowing the break to enlarge too much. In this case, if I remember correctly, we did again an optic capture, and yes, we did an optic capture and put the lens in the bag, and since the break was not huge, it was just a central 2 millimeter break, we still got away. Now coming on to another situation where we again were operating this posterior polar cataract, let me take you, the principles again remain the same, but let me take you to the end of this procedure where we are trying to remove this cortex and we end up creating a break, and then I'll show you what I would do today not to let a break happen. So here what happened is that we had dissected out everything and disengaged everything from the equator, but the last part probably was still attached in the center. So I've done everything right, and here I have freed up the whole epinucleus from everywhere except the posterior plate, which is obviously to be done the last, and as I pull it, suddenly the PC break develops in spite of doing everything right. Now what I would do today is to show you this last quick video in 30 seconds, and then I'll pass on. to the other speaker. I would today go with a similar rhexis, a good hydrodelineation, and after that reaching that last part where I've managed to disengage everything from the periphery, debulked the epinucleus, and you can see that the last part remains attached. Now, instead of trying to go with fluid and go with bimanual IA, I'm going to use viscoelastic for a visco separation. I know that this chunk is attached. You'll get the feel. So when you are reaching towards the end of the case, you'll know whether this thing is free floating or it is attached to the PC. If you notice that it is not free floating, then you can just inject visco from here carefully, and the visco will cause a separation plane to develop and you will not get a PC break. This is probably the only way you can save yourself from a PC break. If at the end of surgery you still have a posterior polar plaque which is attached to the PC nicely, because there is no other way that you can avoid it. If you try to lift it off with bimanual IA, you will invariably get a break and then you can save the day. So I think these tightrope situations on posterior polar cataracts can be handled well using these difficult few maneuvers. I'll ask now Dr. Kumar, if there's a quick question I can answer. Anybody in the audience has any question on this, then we'll go on to the next talk. Perfect. So Kumar, I think you can
Only
start.
one comment, Gaurav, that recently I tried to convince all my posterior polars into the femto. Because on the femto you have the OCT, and on the OCT you can actually see the posterior capsule. So if there is a part going through and through, you can anticipate a disaster in that case. But you may feel there is an onion ring, you may feel there is it. Recently I had a case where I got the patient convinced for a catalyst for a femto. The patient agreed. I got a UBM done to make sure what's happening at the posterior capsule level. All I got back as a report that there was nothing going through, and the posterior capsule was very, very thin compared to a normal posterior capsule. So one more thought process, that if you convince them for a femto, you will know how the posterior capsule is going to behave, and accordingly your strategy for surgery can change.
I agree. The OCT actually shows you quite nicely if the PC is already broken or if there is some debris which is located right behind the PC. But it's a double-edged sword, Kumar, and I would be very careful. I especially worry about if you're using for nucleotomy settings which are going to produce a lot of bubbles, and they can increase the intralenticular pressure. So I typically choose a strategy where, of course, you have the offset more than 500. I normally go to 1,000, 800 or 1,000.
Yeah.
On the other hand, you can also choose a strategy where you are not using too many, you're not using a strategy where multi-passes you're making, because that
I
takes
only
more
make
time and create more bubbles.
6 cuts,
Exactly.
nothing, not
So
even cubes, only 6
exactly.
cuts.
I don't do the cuboid, so it's very important to choose the right nuclear fragmentation strategy if you're going to use a femto. But as I said, it's a double-edged sword. So.
Okay, I'm going to talk, thanks Gaurav for this opportunity. I have to run to the other hall. I'm going to talk about subluxation, what next. Now, zonular dialysis can be happening during surgery, which is iatrogenic, and it can be congenital, it can be acquired. Early detection, of course, is a key. So we know the pre-existing causes. Acquired can be traumatic, hypermature, cyclitis, uveitis, systemic conditions like Marfan's, homocystinuria, etc. Now, there is a sign when you do your rhexis, and that will tell you whether your zonules are weak or not. So we have to imagine two zonules. There are anterior zonules and there are posterior zonules. So what happens and what is the sign? Now look at this video. I'm doing a simple CCC. When the anterior capsule causes this traction here, can you see this folds? That means the anterior zonules are weak, and this patient will cause problem during surgery. You have to be careful, and you will need an endocapsular ring. So this is one sign that you will get only during your rhexis, how the anterior capsule. So patient does not have donesis. You cannot see a dialysis, but you know that the zonules are weak, and this is one sign that you will get during your CCC that is there. What happens, of course, iatrogenic phacoemulsification can cause a dialysis, excessive manipulation, lens, irrigation aspiration, IOL implantation and manipulation can also cause this. The important thing is do not panic, stop and reassess. And then how to go ahead. There are multiple signs that you will get to see. The rhexis, which is round, becomes eccentric. Movement of the lens becomes difficult. Phacodonesis can be seen. Manipulation becomes difficult. Sudden deepening of the anterior chamber. And if the vitreous comes, there is a bulge coming through. Management, I'm going to show you some videos. This is a subluxated hypermature cataract. And subluxation is almost half a clock. Okay, so from 3 o'clock to 9 o'clock, so almost 90 degrees of subluxation is there. More than 90, rather 180 degree of subluxation is seen. So here I'm going to do a Sionis ring. But what I have done here is very interesting. I've done a femtorhexis. Now see the size of the rhexis. So this is the first time in your life some of you might have seen. Can you imagine a size of a rhexis of 2.2 millimeter? Now trying to do phaco through that is difficult, so this was a mistake I made. That was a new system that I had on my femto. But I did a femtorexis. I just got a nice round rexis. You can see this round nice rexis that I got through the femto. The subluxation is about 180 degrees inferior, and that's why this patient will need a C on his ring. So I've gone ahead and then made the rexis larger manually. Okay? So you can see that I've just removed that rexis, now made a cut, and then I'm doing a CCC on the CCC which was done by the femto. So I've just gone ahead and done a nice round CCC, put a good viscoelastic, and now this bag is going to need support. It's just not going to go ahead and go like that. So I'm now going to put capsular hooks, okay? So now you can see 3 capsular hooks, and now I'm doing phaco. So this is a subluxation of 180 degrees, not a hard cataract, but a hypomature cataract. We can go ahead and do phaco. Once the phaco is done, I'm now going ahead and preparing, release the capsular hooks. Now before you put in a Sionis, it's important that you release your hooks a little bit so that the Sioni ring does not come in the way. Go ahead, take your Sionis ring and go ahead and put it there and pass it on. So this is putting in a subluxation a Sionis ring. Once the Sionis ring is put, you really don't need the support of the capsular hook anymore, and you can actually go ahead and remove it. And once this, you can see that the Sioni ring goes in place. Once it goes in place, you pass the needle above the bag, go ahead, pass it out. It's a railroad technique. Go ahead and tie a knot and pull it. So I've got it exactly at 90 degrees across, that is in the center of the 180 degree subluxation. So this is passing the Sioni. You can see the hook and you can pull it a little bit, tie a knot, and this works quite well as far as the subluxation goes. So this is a good technique to use when your subluxation is 180 and above, and it does quite well and holds on. So you have multiple segments available like this depending upon the amount of subluxation that you have. Now important, another trick as far as surgery goes is how to put an endocapsular ring before phacoemulsification. There is always a fear that you will trap your cortex. So that's one thing that I'll show you. After nucleus removal, cortex removal is easy, bag placement, aspiration, and of course difficult before this. I'll just show you a trick. There are various sizes available, 10 by 12, 12 by 14, and 11 by 13. Multiple sizes are available. Different types, the right, left, bilateral, both way Sionis, different emerged segments are available. This is how the Sionis ring actually looks. Now, how to put an endocapsular ring? Now, this is a traumatic cataract. There is a subluxation here. There is a dialysis. So I'm going to actually even cosmetically improve this. There's vitreous coming out. Stain the vitreous. Do anterior vitrectomy. Remove the vitreous strand from there. And there is a subluxation noted. You can see from about 9 o'clock here till about 6 o'clock. This 3 o'clock, about 190 degrees of subluxation is there. Once the anterior vitrectomy is done, I go ahead and do the CCC. Now, once you've done your CCC, the trick of putting the endocapsular ring is you have to put viscoelastic just below the anterior capsule. So go to the level of the anterior capsule, put a viscoelastic and press the cortex down. Once you've done that, you can go ahead, and this has to be done all around, okay, all around the CCC. So I'm not done phacoemulsification here. I'm going ahead and putting the endocapsular ring, and then you really don't need any capsular hooks. Your support is good enough. One can go ahead and do phacoemulsification. Once the phacoemulsification is done, go ahead and put your IOL in position. And here I'm doing a 4th row pupilloplasty. So you can see that first loop gone, second loop gone, and at the end of it you have a nice round pupil. So I'm showing a 4th row pupilloplasty. Now another thing is, this is a femtorexis in a subluxated case. So you can see the subluxation, again 90 degrees of subluxation. You can see a nice round rexis. I'm taking an incision in this direction. Once I've taken the incision, I'm going to go ahead, put the capsular hooks before doing anything else. So I'm supporting the capsular hooks. As far as the trick of placing the capsular hooks is, you should not be corneal. You should be scleral. So the more posterior you are, it will be easier for you to put the capsular hooks. For iris hooks, you have to be anterior, okay? So if you are by mistake making that anterior incision, your capsular hooks are not going to really work. We go ahead and do phacoemulsification. Now see what one stage what happens here. I've finished phacoemulsification and you will see that the capsular hooks actually come off. And you will see that happening, and then the bag goes towards it. Don't worry, because the rest of the zonules are very, very good, good support. So you can see that the bag has actually gone off. The capsular hooks have come off. Don't worry, put in a viscoelastic, re-engage the capsular hook, put in an endocapsular ring, and this is all fine. So there is nothing to worry here, really not an issue, because the rest of the hooks have put in viscoelastic, again got in the capsular hooks, put in the endocapsular ring and gone ahead. So I'll show you as far as the method of putting the capsular bimanual method. Now this one method of keep putting the endocapsular ring, it's a bimanual technique. I never go through the main incision. I always go through the side port. Remember this. I got a T in my right hand, depending on your righty or lefty. I got a Sinskey hook engaging the endocapsular ring of the eyelet of the endocapsular ring, going on, holding it, releasing it. Now once you release it, your T or a Y can hold on to the endocapsular ring. Once you are there, just go ahead, hold it, and just put it like this into the bag. So this is one bimanual technique of putting the endocapsular ring. Remember, always go through the side port and not through the main incision. Again, the same technique here, just to show you how to put in the endocapsular ring before phaco. This is an RK operated patient. I'm going ahead and doing a rhexis. This is video guided. Now this is what I wanted to tell you. The trick is to inject before doing phacoemulsification. I'll take 30 seconds more. To put viscoelastic below the CCC all around till the equator of the lens. Okay, so I'm putting a heavy viscoelastic, pushing the cortex down all around till the equator. So I've created my space. Once I've created my space, I'm going ahead and putting the endocapsular ring. This will not entrap your cortex, and this will make your life much easier later on to remove the cortex. So this is just going ahead and doing phaco and then doing bimanual IA and removing the cortical fragment. This is a high pathological myopia. So it depends on what you want to use, iris hooks, capsular hooks, endocapsular ring. This will make your life much easier. These are capsular hooks, which I showed you already, which have to be placed when it is subluxated. In summary, reassess, don't panic, nothing really to worry. You have different things to your aid, like you have good viscoelastics, you have capsular hooks, you have endocapsular ring, you have Sionis ring. All of this with lower parameters in phacoemulsification makes your surgery sure shot today. So there's really nothing much to worry. Only one last 30 seconds, I'll show you a case you might have never seen in your life, a very successful phaco, okay? And you can see that it's beautifully done, but this is what I call PC radial sign. So if you see on the posterior capsule radial lines like this, okay? You can see the radial lines on the posterior capsule. These are the radial lines, a beautiful phaco and a round CCC, and now see what happens when I put a viscoelastic. Okay, I'm putting viscoelastic, the whole bag begins to move. Can you see? And keep watching this area, subluxation, keep watching. Now go, I realize that something is happening here. I put in viscoelastic in the opposite direction to bring the bag back. Again, the subluxation happens there. That means the posterior zonules in this case are very, very weak. Even the anterior zonules are bad, the posterior zonules are bad. Go ahead and put in endocapsular ring and go ahead and then put in an IOL. So this is one way of handling the different subluxations. Thank you.
Thanks for those excellent videos, Dr. Kumar. We'll have time for one question. I'll in the meantime ask Dr. Shreyas to get ready for his lecture. And so any questions for Dr. Kumar? I think he showed some very nice ways. If nobody else has a question, I have a question.
Doctor,
okay, yes, Harshul.
Dr. Kumar, now we have many companies which are making the capsular tension segment. So now have you shifted to CTS or still your preferred is Sioni ring only?
Whatever that case needs. I go on individual basis. Like Sionis if it is more than 180 degrees, otherwise if it's just a support.
So then we can use two CTS also.
Then you can use two, yeah, but that's depends on what.
It's easier to insert.
Yeah, it's much easier to put a segment than doing anything else. True, that's right.
Yes, and another advantage is even if you have a small PCR, or you can use CTS. Yes, but if you have a PCR, you can't use Sioni CTR. Yes.
Again, that video you just showed where he injected viscoelastic. Before placing a CTR, we need to be very careful that the viscoelastic is going within the bag. It's going outside, the dialysis will increase.
Kumar, I noticed that you seem to enjoy doing femto rhexis and this thing for all your subluxated. So is that your preferred way? And then I have another question for you. It is your preferred way. Now suppose you had a patient who needs, who has a subluxated cataract and you think he's going to do really well with a femto cataract, and you know, you think, so, and a patient can't pay, and you know, many times we do kind of, you know, offer patient surgery when we even if they can't afford. Would you still choose to do a femto in a subluxated cataract even if patient was not ready to pay and you thought, which would then tell me that yes, it may really makes a difference in your surgery?
No, I wouldn't mind spending from my pocket, and if that becomes difficult at times, I'll refer the patient to Dehradun.
Thanks. So, Shreyas, I think you have a very interesting tightrope situation to discuss, and let's hear it.
Good morning, one and all. And at the outset, I would like to thank Dr. Gaurav Luthra. Thank you so much for including me in your course and for the opportunity to talk. So I'll be presenting to you all about cataract surgery in extreme hyperopia and shallow AC. So when we start discussing about extreme hyperopia, it's really important to know what kind of situation, what kind of eye that we are being faced with. Because small eyes comes in different sizes and shapes, even though they are small eyes. Now, you have a micro-ophthalmic eye as compared to a normal eye, which is actually reduced in axial length, but the anterior chamber size, relative size, the anterior chamber depth, and the size of the lens is fairly proportionate to the size of the eyeball. In a relative anterior micro-ophthalmos, a less recognized and a rarer entity, it is the axial length itself may not be greatly reduced, but it is the anterior segment which is relatively smaller, and hence the term relatively anterior micro-ophthalmos. The definitions are a little variable. There is no standard criteria which is widely accepted, but anything less than 20.5 millimeter is considered a micro-ophthalmic eye. Now coming to this special entity of nano-ophthalmos and how it differs from micro-ophthalmos is that here the anterior chamber depth is relatively shallower. It is a shallow AC. But you have a greater lens thickness, and more importantly and more differently, you have a highly increased scleral thickness. As a result of this, these eyes, their normal uveal perfusion, which takes place through the collector channels, the scleral channels, and the transscleral diffusion, does not happen as easily, and they are at higher risk for uveal effusion, higher risk for suprachoroidal hemorrhage. Also, this is a large lens in a small eye. So when you're removing this during a cataract surgery, this sudden decompression itself can lead to some amount of effusion and rarely a suprachoroidal hemorrhage. So the coexisting challenges which are there in these patients are lower endothelial counts, which many of these patients may have, angle crowding and presence of angle closure glaucoma, uveal effusions as I already discussed, and as a result of this shallow anterior chamber, there's an increased risk of iris prolapse as well. The IOL power challenges is an entirely different entity and very challenging in these eyes with high hyperopia. As in essence, one, you have very large powered IOLs which are not available as part of your standard library, which is available with most companies. There is difficulty in predicting the effective lens position. As earlier discussed, the lens thickness varies, the ACD varies. Even with the shorter axial length, you can have normal ACD, you can have shallow ACD. As a result of these and the variation in the lens thickness, ELP, which is an essential part of all 4th and 5th generation formulae, becomes very difficult. And in these smaller axial length eyes, even a half a millimeter or 1 millimeter variation in the axial length can give rise to a large refractive surprise as opposed to a normal or a high myopic eye, where even though you may have a biometry error, the final refractive surprise tends to be quite small. Which IOL formula to use? Earlier we were using the Hoffer Q as more for shorter axial length eyes, but with the advent of newer formulae like the Barrett 2 and the Hill RBF, they seem fairly suitable for all kinds of axial lengths. In the preoperative period, important to give mannitol or glycerol to these patients. Gentle orbital massage is also extremely important, though a simple maneuver can really help ease surgery. Now, the controversy regarding prophylactic sclerostomy. When do you do the sclerostomy, the timing, and whether it is really required in the modern era of phaco emulsification. So I want to talk to you about two separate studies. One, a review which has included a large number of eyes which have discussed the use and the pros and cons of using a prophylactic sclerostomy. Now, though they were very useful in the ECC era, in phaco emulsification with a closed anterior chamber, the use of prophylactic sclerostomy is still questionable. And then they also go on to ask the question, in an eye which is highly pressurized globe where you're doing a phaco emulsification, is it nice to have a weak point, a potential weak point in the posterior area with a potential risk for choroidal prolapse during that area? So they have gone on to recommend that if you're doing a sclerostomy, it's better to do it 5 to 6 weeks in advance and then before you schedule the phaco emulsification. Whereas a recent study published from Aravind Eye Hospital has shown that in cataract surgery, that sclerostomy even done concomitantly with the surgery, it does help and does reduce the risk of complications. Though unfortunately they have combined cases of both phaco and small incision cataract surgery, making the group a little more composite. And they have shown that in SICS it's definitely more useful than in phaco. So intraoperatively it's a crowded AC, the mydriasis is often poor, as I will show in subsequent videos. Now the question of whether to use iris hooks or rings. In these corneas with shallow AC, maneuvering the ring might be more difficult, so hooks might be more preferred. A limited anterior vitrectomy is best avoided in these eyes, as there's an altered anatomy. Even the area where you're going to put your pars plana port might be quite altered, and you might end up creating a retinotomy or even damaging the lens. So this is a eye with nanophthalmic eye with poor mydriasis and a shallow anterior chamber. Now it is a little bit more difficult to hook the iris in a nanophthalmic eye as compared to a normal eye, as the chamber is quite shallow. So it's useful to put a cohesive viscoelastic just under the iris to tent up the iris a little bit. You could do this in normal cases as well, but in a normal case you might get away even without doing it. You might be able to hook the iris quite easily, but in a nanophthalmic eye it becomes a lot easier to hook the iris once you've placed a little bit of cohesive viscoelastic underneath. Now in an already shallow anterior chamber, as you tent up the iris, it can become quite shallow and can get in the way of your phaco probe. Importantly, as Dr. Kumar alluded to earlier, make your iris ports quite peripheral. Do a very gentle hydrodissection, as fluid mismanagement, misdirection is very common in these eyes. Now you can see that it's quite difficult putting the probe inside because the iris is tented up a little bit, and it becomes quite challenging to bring it. But once you are there inside, the iris does fall back, and you have to do a good direct or whichever procedure you prefer, a very good in the bag phaco. Now it's important that these are shallow anterior chambers. The endothelial count can also be compromised. Do a very central phaco. Bottle height has to be adjusted appropriately, and if you're doing active fluidics, it becomes quite useful in these cases. During your last pieces, make sure you lower your parameter, as the risk of positive pressure is quite higher in nanophthalmic eyes as compared to regular eyes. And after centering the IOL, you can go ahead and remove the hooks and proceed. Now 5 is definitely better than 4, especially in these nanophthalmic eyes. After you've put 4 hooks, you can actually make a limbal incision, which is just below your main clear corneal incision, and put in a 5th hook. In these cases, you could make your clear corneal incision a little bit more anterior, so that you have very easy access and that this iris doesn't come in the way of your phaco probe, making the case a little bit more messy. And this kind of arrangement with 5 hooks and a little bit more anterior allows you to take the phaco probe in very easily with absolutely no difficulty whatsoever. This is another scenario where you have a hyperopic eye, but with an intumescent cataract, where the chance of rhexis runoff is quite high. So using a very high molecular weight cohesive viscoelastic definitely becomes useful. If there is a little bit of fluid, slightly gently aspirating, tapping out the fluid before you continue with the rhexis definitely becomes useful. You could either start with a cystitome, but please do not hesitate to switch over to forceps wherever required. Maybe even start with a forceps. But let us always aim for a small rhexis in these eyes. They can always be enlarged at a later stage. If the rhexis is too small to begin with, you can do your hydro maneuvers and then enlarge it. Or in this case, where it was sufficient for me to go ahead with my phaco, I went ahead, completed my phaco in this case, and then went ahead with my micro scissor and forceps to enlarge the rhexis, and then you can have a uniform 5 mm rhexis as desired. Tackling the residual error, I'll just take 1 minute, sir. Tackling the residual error is quite a challenge in these eyes. Now if you have a small residual error, you could do a bioptics, do a laser touch-up and correct the hyperopia, but very often you're left with higher residual errors. You can either go for a piggyback lens or go for a customized IOL. The problem with customized IOL is that the risk of biometry errors in these eyes is very high. And even after using a customized IOL, because of biometry issues, you might be left with a large residual. I'll quickly show a quick example with a patient of axial length 16 millimeters who's come for cataract surgery. You can see using one formula and one device, we have IOL power 58, and using the Varion and Holiday 2, the IOL power is 49. So widely variant that it is so very difficult to arrive at a precise IOL power calculation. So it's better to go ahead with the standard 40 diopter, which is the maximum you have in the standard IOLs. Go ahead, implant the 40 diopter and then look at the residual. In this patient, we had something in between the two formulae with a +6 diopter of at the optical plane. Now you can easily go ahead and correct it using a piggyback lens. You can use the Nishamin nomogram, which basically says for every diopter of hyperopic error at the spectacle plane, the IOL power has to be 1.5. So for a 6 diopter residual error, we went in for a 9 diopter lens. So this is a sulcoflex lens being implanted in the sulcus. It's a hydrophilic lens. A lot of people ask, it's already an anophthalmic eye, crowded chamber. How can you put in 2 lenses instead of 1? Will it cause glaucoma? We must remember, we have removed a 4 millimeter thick lens and placed a 0.5 millimeter IOL inside, a 0.5 millimeter thick IOL inside. So therefore, you actually have ample space to put in a sulcoflex lens. This lens has a nice 6.5 millimeter optic with these undulating haptics, which really helps it be very stable in the sulcus. It has both toric and multifocal variants, which are also available, though quite expensive. And additionally, it has a posterior concave surface, which ensures that the lens is vaulting above the lens, which is already resting in the bag, and there is no interlenticular opacification, which was seen when 2 lenses of similar material were placed in the bag. So to summarize, with careful preoperative planning and use of adjunctive agents like hooks and cohesive viscoelastics, we can ensure optimal outcomes even in these challenging situations. Thank you, sir. Thank you, everyone and all, for the kind attention.
I think wonderful tips, Shreyas, and these are some of the most challenging eyes to handle. And any questions from the audience before we go on to the next talker? Harshul, you wanted to ask
Yeah, Shreyas, you very nicely showed the technique which Otting has also described, that whenever we are using the iris hooks, it's always better used in the diamond configuration. So your iris hook should be there just by the side of the main incision, so that you pull the sub-incisional iris and it doesn't come in your phaco probe. And the next iris has to be opposite to the main incision and 2 iris on both sides. I've used in these cases malignant ring. Of course, they are difficult, as you said. But now we have the 2.0 version of the malignant ring, which has a thinner profile, which goes through 2 mm, and also because of the thinner profile, we can use in this the crowded anterior chamber and angles which is there. But of course, they are difficult to use. But we have BHEX ring now,
which is even thinner.
Yes,
and
it has a very thin
very
profile, and yeah, that's also a wonderful tool. Very nice videos shared. Dr. Gaurav, one question. As Shreyas showed that if he has a patient who has power of plus 49, you'd like to use 40 and then sulcoflex or piggyback.
Yes.
Don't you think it will do more overcrowding of this? Or in the first place only you would like to
put in
get
a high-powered customized
yes,
lens?
Yes.
So both options are possible, and only thing is that inserting a 49, I mean, if you're trying to correct it whole thing in one go, those lenses are very, very difficult, and you'll need a big incision, and they will not go through any injector. So that may be another consideration, because if you're using a piggyback, at least you don't have to, enlarge the incision. And what I've realized is that yes, these eyes are really tight, but you can still manage to put in a piggyback because the lens profiles are, such that they will still accommodate it. So somehow I would prefer to go, because the optics of a lens which is customized to such a high power would probably not be that easy as well. I mean, the quality of optics.
But what about the size of the nanophthalmic eye? And this height of the sulcoflex lens will never change.
No.
True,
You
sir.
removed a lens which is so thick. The
right.
natural lens is thick. So
4
when you have
millimeters
removed
of a
it, now
phakic
there
lens
is
which
enough
has been
space to
removed.
place 2 IOLs in the eye. IOLs are so thin.
Yeah, as compared to the natural lens which you're removing, you will have 2 lenses which will probably come less than what the natural lens of the eye was occupying.
And besides, the advantage of putting a sulcoflex is your effective lens positioning in these extreme eyes is somewhat like, I think, a post-refractive surgery
my
dilemma.
personal choice would also be to do that, but
yeah.
and I have burned my fingers with customized very high-powered lenses once or twice, and they don't come out that easy to inject, to insert, and they don't go through the injector. You could actually damage them in the injector if you're trying to put it through an injector, and then otherwise you have to have a bigger incision to put them in. So they're less maneuverable. But if your experience is different, I mean, have you had a very...
No, I don't have much experience. That's why I was asking you.
So the other issue is not just, even if you have a good accurately powered IOL, accuracy in biometry is very difficult and very challenging. That's why I showed that particular case where 2 IOL formulae showed very high variability, and the final residual was somewhere in between the 2. So it becomes the refractive or the management of the refraction becomes easier in a secondary stage as opposed to primary, where the biometry itself is challenging.
Thanks, Shreyas. And so I think we'll go on, because now we still have 2 talks left, and none other than Dr.Chitra Ramamurthy, who's brilliant with her cataract surgeries, and she will be speaking on Phaco in patients with the presence of corneal opacity and compromised corneas.
A very good morning to one and all of you. This might be a little challenging topic to me, because I'm a cataract refractive surgeon who do glaucoma work, but here I'm going to play around with the cornea too. So bear up with me. taking you on phaco emulsification in corneal opacity and compromised cornea, it clearly tells us that there are two challenges. When you're doing a cataract surgery in a patient with a corneal disease, there is a possibility that you would potentiate the progression of the corneal disease, or if you in a corneal diseased eye, you do a cataract surgery, it could actually limit your surgical technique because of the limitations of the corneal problems which are earlier there. So probably something very basic which we can do is, first, if the ocular surface doesn't look good prior to the phaco, lubricate it enough, use punctal plugs if the tear quantum is less. If there is a mild inflammation, ensure that you use topical steroid drops pre-operatively, use preservative-free medications, ensure that you carefully plan your wound location because the cornea could be thin in a particular area with an opacity or a corneal disease, and most importantly, these measures are needed to avoid exacerbations. So taking you through this case, basically, this is an eye with a corneal opacity, and this patient was not ready for a corneal graft. He just wants some amount of visual rehabilitation. So then it's mandatory that we use enough viscoelastic, do a good syneculisis so that you're separating the adherent leukemia from the other areas. And it also makes sense to use pupil dilators, because I think placing iris hooks is not quite a child's play once you get the hang of it. When you're doing a rhexis, try to be a continuous process of rhexis, not lose the rhexis and keep trying to revert back, because the size of the cornea opacity might be limiting. Trypan blue should be injected generously, not just to stain the capsule, but also the cortical fibers. Most importantly, ensure it's a slow surgery so that you're constantly visualizing what you can in that limited area. You could do a little more than a gentle hydro or a multi-quadrant hydro so that it just tilts up the nucleus, so that it's not exactly supracapsular but sort of easier because you get better access to the nucleus edge. And then when you place the lens and when the surgery is done, you do realize that you have given some amount of ambulatory vision to these patients, and you should not push yourself away from doing these surgeries. Taking you on further, if it is supposing a dense corneal opacity, you could do a PTK to thin out that opacities to get a visibility, a band-shaped keratopathy, scrape the calcium plaques, and other things which I had already alluded to, make it a deliberate, careful surgery. Now, this was a case of a dense opacity, and the patient was ready to do a combined phaco and a PK procedure. So the surgical steps need to be identical, but I did scrape the corneal opacity surface so that some amount of transparency was available as I was doing the surgery. Rhexis, the capsule has to be well stained, and ensure that you do not lose the rhexis all through, and ensure that you do not fluff up the cortex, and so that the visibility is there all through. But in this particular situation, the advantage was I could get the nucleus a little more nearly supracapsular and do the surgery, because there was no need to protect the endothelium, and it was more important that I do not damage the posterior capsule, and then placing the lens, and then doing the routine procedure of cutting the button and then placing a donor button. So the surgical procedure per se, if followed properly, takes you forward. Then again, this is a case of a corneal opacity, and the patient was very keen on, because he had a significant astigmatism. So we all know that toric IOLs have a role to play only in regular astigmatism, but you could play around a bit if there is some amount of regularity in the irregular astigmatism, which in other words, you're debulking the extent of astigmatism, although you cannot correct the whole portion of it. Some better vision of BCVA and UCVA you are able to provide this patient is definitely a way forward. But sometimes you could be challenged because you do not know the exact astigmatic component, so the K values may not be possible in the same eye, the measurements. Try to take the K value in the same eye. If not, try to take the K value of the other eye. But then we need to understand, if it is a younger patient who has had a PK done, that was a previous case was a PK done. So if it's a younger patient for whom a PK has been done, and you think that this patient may need a regraft, somehow it doesn't make sense to place a toric IOL earlier on, because once you need to do a regraft, basically the toric IOL is just reflecting the corneal astigmatism, and when you remove this cornea and going to place a different cornea, then it may not be possible. But in these cases, instead of a PK, you do a DSEC or DMEC, makes sense. The other big advantage you could utilize is using using an endoinumulator, whether you go through the limbal route or make a transconjunctival injection and incision and go through the
past planar growth. What it does, it gives a back scatter of light, and this back scatter of light, if you can see, of course you need to stay in the capsule and the cortical fibers if you can, but you are able to get visibility. This case was further more disturbing because there was a flutter in the eye, and there was a tendency for the iris to come into the phaco probe. So you need to be even more careful, and because there could be the posterior capsule bouncing up and down. So the surgery has to be extremely gentle, but this endo-illuminator would tell you that we are able to do a complete surgery and then place a lens and get away with it. Again, the other challenges, supposing you're doing a phaco in a case of a PK, the challenges are that there could be leakage from the corneal incision, and we need to remember in a post-PK eye, there is pellucid type of changes which occurs in these long-standing grafts, which the peripheral cornea could become thin. So when you do your corneal incision, try to keep away beyond the graft primarily, and ensure that you definitely suture the wound, because you do not want the AC to get shallow, and we go ahead and remove these sutures after 6 weeks. Again, the amount of astigmatism, if it's high, you could always ensure that the K readings from the opposite eye is taken, and you could do a same correction in the same procedure. Again, if it is a DSEC eye, we need to avoid leaky wounds, but one important thing here is when you're placing a DSEC graft, you should remember that there is an increase in the negative posterior corneal curvature. So these patients could have about 0.75 to 1.5 diopter of myopia. So you should anticipate this hyperopic shift and make these small adjustments in your IOL power calculation before you place the lens. Also, we need to remember if you're using a larger graft, there's a greater hyperopia which could occur. However, the interesting thing which I also learned was the induced astigmatism in a DSEC is less, so toric IOLs are still possible. Again, in a DMEC eye, this negative power coming on from the lenticule is not there. That's a big advantage. The chances of an iatrogenic cataract is also less if you have done a DMEC before you do a phaco surgery. A simultaneous surgery is also possible because it does not compromise on the endothelial graft cells, and a normal IOL power nomogram could be used. In a keratoconus eye, the important thing is incisions have to be absolutely safe. Toric IOLs is possible for the regular component of the astigmatism, and in a severe keratoconus eye with corneal thinning, we need to be wary of wound leakage. I'm just briefly trying to show you the video here. This is a case of fugues. We all understand in early fugues, you could still do a gentle phacoemulsification, do a soft cell technique, ensure that you are protecting the endothelium to the best possible way. But if the corneal thickness has increased over 640, if the patient has complaints of visual blur and he has early morning glare, these are clear indications that you need to do a DSEC in the primary procedure, and then you score out the Descemet's membrane and place a fresh graft and ensure that you have a tight closed wound. Just 1 or 2 slides left as I take you on. The cutoff point, which I already told you, is 640, and ensuring that your phaco parameters. Again, this is a case of a very bad opaque cornea. Then you could just remove the anterior opaque cornea, and then there is some amount of visibility which is ensured, and you stay in the capsule and do a gentle phacoemulsification. And then you could go ahead and remove and go ahead and do a posterior PK as is shown. Again, if it is a Stevens-Johnson syndrome, you need to stabilize the ocular surface with steroids, artificial tears, cyclosporin, punctal occlusions, use amniotic membrane grafts, do everything which you can do, and then combine it with a careful phaco. Again, if you're doing in a post-herpetic case, a herpes zoster, a herpes simplex, it makes sense to start the antivirals a week or 2 before and follow it up to about 4 weeks or beyond to prevent reactivation. So there is so much more that could be discussed about phacoemulsification in the presence of corneal opacity and a corneal disease. But definitely a careful, wary phacoemulsification should tide you over those problems. Thank you.
Thanks, Dr. Chitra. And before Harshul has some questions for you, I'll invite Dr. Lionel Raj to take over because Susan couldn't make it. He's kindly agreed to cover Dr. Susan's topic. And once you're ready, Harshul, you had some question for.
Thank you, Dr. Chitra, for wonderful presentation. So, for the beginners or the surgeons, I'd like to know that which OVD would like to recommend to use in cases which have, the bad cornea, endothelial cell count is not good.
Yeah, I would prefer to use a viscoat in these eyes, in these situations.
But if they can't, patient can't afford viscoat,
then I would just use methyl cellulose, use generous amount of methyl cellulose and go about doing a slow surgery, keep going back and putting it. Each time I bring my instrument out. So,
but there are many Indian companies also which are making, the products like viscoat.
Yeah, we can use.
So have you used and any experience with?
No, I use viscoat only in these situations.
Dr. Gaurav?
I think there is one which I have used, although I still trust viscoat
as
to be the best.
Yes, I also use
frankly,
viscoat
the
only.
price difference between what is from the Indian company and viscoat is not that huge that I would want to. But I've used the one which comes from Orolab, and
I've used
it's
too,
pretty good as well. It's pretty good,
Yeah.
and I've been convincing them to bring the prices down, to like maybe half or less of viscoat. If that happens, then definitely it'll make more sense to use that.
Yes. So next we have Dr. Lionel Raj, who will be speaking on hanging on a thin thread. Yes.
Good morning, everyone, and I'm on behalf of Dr. Susan Jacob. I do not have any financial interest, neither does Susan in this particular video presentation.
Dr. Jacob has a patent pending for the paperclip capsule stabilizer. None of the other producers have any financial interest in the products or procedures shown. Subluxation, whether as a planned or an unplanned encounter, is always a challenge. Dehiscence up to 3 clock hours may be managed with capsular expansion with a capsular tension ring. If greater than 1 quadrant, scleral fixation is also required. However, suture fixation of the capsular bag to the sclera needs surgical expertise and involves complicated, time-consuming, difficult maneuvers. Therefore, for cataracts with more than 3 clock hours of subluxation, we would like to introduce the paperclip capsule stabilizer. As the name indicates, this is a paperclip type uniplanar device made of flexible blue PMMA, which has a central rounded extension that continues as a flange on either side. The hook also has a 13 mm long haptic with indentations that allows for a firm grip within a scleral tunnel. The body of the device is meant to fixate onto the rhexis rim in a paperclip fashion, and the haptic passes outwards through a sclerotomy and is tucked into a 26-gauge scleral tunnel. Degree of centration is adjusted by adjusting degree of tuck. This evolved from the original glued capsular hook concept. The extent of zonulodialysis is assessed, and a scleral flap is created, centered on the area of zonulodialysis. The Phaco incision is oriented away from the dialysis to prevent extension from the movements of the Phaco tip. On the cover of a dispersive viscoelastic, a rhexis is performed. On the side of subluxation, care is taken to keep an adequate rim of rhexis for the device to engage onto. A 23-gauge bent needle is passed to create a sclerotomy under the scleral flap. The haptic of the hook is then passed into the anterior chamber and grasped with an end-gripping microforceps passed through the sclerotomy. It is then externalized through the sclerotomy while at the same time inserting the body of the hook into the anterior chamber. Additional translimbal capsular hooks may be implanted if additional support is required. The rhexis rim in the area of scleral flap is then engaged with the hook by passing the flanges above and a central rounded extension below the rhexis rim. This clips the hook onto the rhexis. The haptic is then trimmed and tucked into a 26-gauge intrascleral chariot tunnel. The transscleral paperclip capsule stabilizer, as well as the translimbal regular capsular hooks, operative support to the capsular bag during all maneuvers. A capsular tension ring is then inserted gently, taking care that it is implanted towards the side of the zonulodialysis. The capsular tension ring provides capsular phoneal expansion, prevents floppiness of the posterior capsule, as well as accidental posterior capsule aspiration into the Phaco and IA probes. Finally, an IOL is implanted gently into the bag. Centration of the IOL is assessed and, if required, can be adjusted further by adjusting the degree of tuck of haptic. This is unlike sutured fixation, where final centration depends on tautness of suture, and once the knot is tied down, readjustments are difficult. The paper clip hook anchors the bag to the sclera easily, giving vertical and horizontal stability while allowing easy adjustability. The paper clip capsule stabilizer has an advantage in subluxated in-the-bag IOLs over other sutured devices, as it engages onto the rexus quickly. Scleral fixation and centration can be quickly and easily attained. In delayed in-the-bag IOL subluxations, extensive capsular fibrosis necessitates extensive fornicial dissection in order to implant sutured rings and segments. In contrast, the paper clip capsule stabilizer requires a very small area of dissection to clip on to. Sutured devices may dislocate or drop into the vitreous both intra and post-operatively. However, the paper clip hook is secured firmly via the intrascleral tunnel. Indentations on the haptic make fixation within the tunnel firmer still. A coat hangered configured tuck also helps. As for any device, over-tightening should be avoided. The hooks can also be used for subluxations larger than 8 clock hours, or for progressive subluxations by using more than one hook for better capsular support. Retention of the capsular barrier in large or progressive subluxations does have an advantage over lensectomy, as it allows surgery within the closed and safe confines of an intact anterior chamber. A lensectomy in such cases can cause vitreous disturbance, increasing vitreous prolapse, unintended vitreous traction, and nucleus drop. Post-operatively, the intact capsular barrier decreases endophthalmodonosis and risk of posterior segment complications. We also used it to prevent IOL expulsion in a keratoplasty with subluxated IOL. How about ease of explantation if needed? Sutured devices may be difficult to localize and explant in the event of a dangling device. The paper clip stabilizer is always accessible via the tucked haptic. An additional scleral flap in the opposite meridian allows a glued IOL scaffold to be performed. The paper clip capsule stabilizer can easily be explanted at any stage by releasing the haptic and pulling the hook out. It is therefore easy to retrieve it and continue with surgery at any stage. The hook engages the rexus at 2 points, that is, at both the flanges, thus giving a broad area of contact and a rounded rexus rim. To conclude, the advantages that this device offers include ease of implantation, ease of engaging the rexus rim, and ease of anchoring to the sclera. Complicated maneuvering of long, thin needles in the anterior chamber, as in sutured devices, is avoided. Issues arising with sutured devices, such as long-term degradation, are also absent. Ease of centration and the ability to further adjust centration by adjusting the degree of tuck are further advantages of this device. It offers faster and simpler surgery than sutured devices, and our results have been exciting.
Thank you.
Very nice, Dr. Lionel. I think we all know Dr. Susan is a great innovator, and she has won many awards in Academy, ASCRS, CACRS, everywhere. And I've seen this particular device evolving over last so many years, and now finally it's in shape now, the final design which she wanted.
Started with glued hooks.
Yes.
And now it's come to a clip.
Yes. So what material?
It's PMMA. PMMA, just like IOL haptic in a multi-piece IOL. It's a PMMA.
And it's now available in the market
no,
for everybody to use?
No, it's about
still
to
not.
Yeah, it's waiting for some patenting issues.
Okay. Any questions from the audience?
Cost.
No,
It's
not
not
available
into
till
market
now.
I'm not sure. I'm not sure.
I think mortuary is making it, and
Correct.
they're only going to decide. Okay. Thank you very much,
Thanks
Dr.
a lot.
Lionel. Now, last but not the least, we have none other than Dr. Sri Ganesh, who will be speaking about challenging pediatric cataract surgery situations. We all know he's a wonderful surgeon, and I'll say he's a superman of ophthalmology. Dr. Sri Ganesh, welcome.
Thank you, Dr. Harshul, and I would like to thank Dr. Gaurav Luthra for inviting me to this course on challenging situations. I also do a lot of pediatric cataract surgery, and I would like to share one case which I done recently. This was a 8-month-old child, and you can see this. Before I start the case, I am a consultant to Carl Zeiss Meditech. You can see this is the case that came in. You can see the blood clot there, and this was a cataract with persistent hyperplastic vitreous. You can see the blood vessels there, the tunica vasculolentis as it's called. So the challenge here is these blood vessels can bleed. It's on the posterior capsule, just behind the posterior capsule. So I had to kind of manage this, so I proceed with my capsulorhexis using the forceps. As all of you all know, it's very difficult to, in an 8-month-old baby, the capsule is very elastic and it has a tendency to run off, so you have to keep directing the rhexis inwards with the forceps, and I'm able to complete the capsulorhexis in this manner. The visibility also is not very good. You only have a peripheral glow. After that, this is the hydrodissection. You can do a hydrodissection, gentle hydrodissection. And you can, then I go in with the IA because the nucleus itself is very soft. So that's the hydrodissection, and after that is the irrigation aspiration, and I'm able to aspirate the whole lens. And after I aspirate the lens, you can see that there is a fibrotic plaque with the central blood vessel here, and this is again challenging because this can bleed. How do you do a PCCCC in this? If you don't remove this, it's again going to block the visual axis, and there's no point in doing the surgery. So I go ahead, and here I am just basically irrigating and cleaning the rest of the posterior capsule and removing all the cortical fibers from the posterior capsule. After that, I attempt to do a PCCCC. So put in viscoelastic, open the bag. You can see that rhexis is a little small and irregular here, so we'll have to deal with that later. But before I do the PCCCC, what you can see that I'm using a cautery to cauterize the whole plaque and blood vessels, because if you don't do this, when you're doing your PCCCC or vitrectomy, it can bleed. So I've cauterized the central area, and you can see the blood vessels have completely shrunk there. So this is something you need to do before you go ahead, and this has been demonstrated very well by Dr. Jagat Ram. I think his video won the best video in ACRS, and I picked this up from that video. Then this is the incision there. You can see it's quite fibrotic and tough. So I just make an incision and then put in viscoelastic basically to separate the intrahyaloid from the posterior capsule. And then I go in with the rhexis forceps and try to do a rhexis, but you can see that it's very difficult to do the rhexis. It's because the forces are not like in a normal posterior capsule. You can see that here one area it's fibrotic, the other area it's a little weak, so even on pulling it's not tearing very easily. And then we have cauterized it also. We have cauterized the posterior capsule, that again shrinks and contracts. So after a few attempts, then I realized that I may not be able to do a good rhexis, posterior rhexis, or it may run off. So then I abandon this and shift to a vitrectomy, and with the cutter I'm able to just remove the posterior capsule. So I'm using the cutter to remove the plaque there. So again, the plaque is quite tough, so you have to remove it carefully. But because we have cauterized the blood vessel there, then it doesn't bleed. You can see that I'm eating it away, and it's clearing the visual axis. There's a little bit of a floater there, which is the persistent hyaloid artery there, but that basically would not interfere with the visual axis. But what is important is you have to clear this complete plaque. And then as you're eating away the posterior capsule, you have to be careful that you don't actually clip the anterior capsule. So I just keep injecting visco here. I'm injecting visco in the visco cannula and doing like a dry vitrectomy, but just the visco, which is basically, so you have a little bit of fluctuation there because it's through the main incision. And I'm using the visco cannula to retract the anterior capsulotomy, and then I complete that. So I have a PCCCC done with the vitrector, and then I'm put the lens in the bag, capsular bag. So this is positioning of the lens very carefully in the capsular bag. And once that is done, I find that the anterior capsule is a little small and it can contract. If it contracts, it may dislocate the lens, or again you may have capsular phimosis. So I go in and do a secondary rhexis. This is secondary rhexis using the forceps. So I get a fairly aim for a 5.5 to 6 millimeter rhexis, and you can see I've done a secondary rhexis now, and lens is fairly well centered. I put in air and then suture the main incision, and this is how I managed this case of a persistent hyaloid artery, and then this child is doing quite well. So this is something I wanted to show you. Thank you very much.
Dr. Sri Ganesh, as you showed that it's very important to first cauterize, because otherwise they may bleed a lot. You could have also used the scissors to cut, the posterior capsule plaque. Did you try that?
Yes,
curved scissor.
But anyway, you have to do a vitrectomy.
Yes, of
course. In a child, you have to do a vitrectomy. So I thought I would remove the plaque with a vitrectomy, and I was able to do that. You can also use like a retinal forceps to cut the plaque.
Yes.
You can do that.
Yes. Right. Any questions? Yeah. Any comment, Dr. Chitra? Any questions from the audience? Dr. Ajay, yes.
It was vascular, but after the cautery it shrinks. It shrinks and it does not bleed. So that's why it's very important to cauterize all around, and also the central stalk. Once you cauterize the central stalk, you see there was a blanching. You can see the redness goes away because the blood completely coagulates and it gets blanched. So once you have that, then it doesn't bleed. Otherwise, if it starts bleeding, then it can be a problem.
I think Dr. Durrani has some. Yes.
Yeah. Yeah, you can manage this by a pars plana vitrectomy, lensectomy also, and with a trocar cannula and then pars plana. But this is the anterosegment surgeon's approach.
So we come to a close to
session. To put the IOL, you would still need an anterosegment surgeon.
Thank you very much for being with us. But I think you all should stay on in the hall, because there's going to be another very interesting cataract session, very challenging, which you could watch. Thank you very much for bearing with us.
I'll invite Dr. Cyrus Mehta to come for his course on converting to femtosecond laser cataract surgery from Phaco.